People will take everybody to this wonderful occasion today. We're doing the AFREhealth-UCSF STRIPE HIV dissemination webinar. So this is our own little conference because, as Amelia said, we can't meet in person, but that doesn't mean we cannot meet. So we are doing a little, like we would have done on a conference today, give everybody a time to present their work. So this is the first of this webinars. We will have another one in October, and there seems to be more people that would like to present their STRIPE work, so maybe one in November also. So welcome new people, old friends, new friends, everybody, supporters. A special welcome to Flora from NIH and Dr. Marietjie too from HRSA, and congratulations on Dr. Razak with your promotion to OGAC. We're very proud of you. Okay, so I see Peter Kilmarks from Fogarty NIH are also here. Welcome, Peter. And Mike, anybody else specifically we need to welcome? Okay, so we will ask just a few rules for the day. That you keep yourself muted and your video off to help us with the bandwidth. What we will do when the speakers speak, only that person will show the face, and we will all keep quiet like in an audience, depending on the bandwidth. We will give the speakers 8 minutes to present and hopefully have 2 minutes for questions, but it will be at a conference. If they, by 10 minutes, they're not finished, Mike will gently advise them that the time is up because it's 5 speakers and we've got an hour. But it can be done. If it can be done at conferences, we will do that. So we have a wonderful lineup today from all over our wonderful Africa. From East Africa, we have Kenya. From West Africa, we have Ghana. From Southern Africa, we have South Africa, and then going up to Mozambique and Zambia. So we've got a wonderful lineup today. I will just introduce the speakers by country, and then they will introduce themselves. I would just like to give Dr. Mike Reid from UCSF opportunity to welcome, say something.
Good morning, everybody. From San Francisco, good morning, good afternoon, wherever you all are at. I think everybody is aware of this project, STRIPE HIV, funding from HRSA to improve the quality of HIV service delivery across PEPFAR countries with a vision to enhance interprofessional collaboration. I think you all agree that this has been a really exciting endeavor over the last 12 months. We've had an incredible impact, particularly considering the fact that the COVID pandemic has obviously disrupted, many of your projects. And I just want to start by thanking the funder, thanking HRSA, and particularly Marietjie Razak for his vision in conceptualizing this project, but also primarily to all of you for the work that you put in to make this project successful. And in the midst of COVID, I think there is an opportunity to think about how we can leverage these lessons learned for new models of HIV training and capacity building in this new uncertain era. So again, thanks. Back to you, Marietjie.
Okay, great. Thank you, Mike. Okay, so University of Nairobi, Kenya. Onesimus, you ready to start? You can unmute yourself, show your face.
University of Nairobi. And my topic title is Kenya International Professional Training, KIT HIV, to enhance preparedness for quality HIV service provision. So I started by expressing thanks to UCSF and HRSA for giving us this opportunity. So in the introduction, Kenya is still one of the countries that is burdened by HIV. And from UNAIDS in 2018, the country had a total load of about 1.6 million people who are living with HIV across the ages, and a prevalence of about 4.5%, with the first cascade of 1990, 89% knowing their status, and about 68% on ARVs. Some years ago, by recognition of the fact that HIV was a real burden in the country, most of the pre-service institutions were mandated by the regulatory bodies to come up with a curriculum to provide HIV training. And as we bid for this RFA, most institutions had already embedded the HIV training in their curriculum. However, in tandem with that RFA, there was recognition by the Ministry of Health and more so NASCOP, which stands for National STI and HIV Program. They had already recognized that there were gaps in the training which was already being done to the pre-service students across board by virtue of the fact that the training was kind of harmonized, but there were still gaps that made the students not practice ready in terms of provision of qualitative HIV services. The background, I think I've already alluded to the fact that we were able to mount this training, having bid to that RFA. And in our bid, we had brought on board other institutions over and above the University of Nairobi, which I'll mention along the way. And having been successful in that bid, we did some series of preparation towards the mounting of the training. One of them was faculty meetings on the modules and training logistics. And then we had several meetings with our partner institutions. And then we did a trainer of trainers of the people we were to engage in this training. And then eventually we were able to mount the training. Now, the objective of my presentation today is borrowed from one of the things that we were able to evaluate. And one of them was to evaluate the levels of knowledge and skills gained during the training of the interprofessional pre-service students. I have to distinguish at this point in time that along the way, we also trained residents, or what some people would refer to as postgraduate students. But for all intent and purpose, my presentation today is restricted to the pre-service students. Those are the partner institutions, the University of Nairobi, which was the prime. Then we brought along sister universities, Kenyatta University, Jomo Kenyatta University of Agriculture and Technology, and also Maseno, which is geographically located at the epicenter of where we have many cases load of HIV. Now, the cadres that we chose to train were mainly drawn from the schools of medicine, School of Nursing, and School of Pharmacy. In terms of the methods, we were able to subject the participants to a pre-test questionnaire, and then the training was unified in terms of, after the initial evaluation, most of the training became harmonized. And then we were also able to do a post-test questionnaire. And then at the tail end of my presentation, I'll give an overview of the results. Now, these are the modules that we chose. Some of them are compulsory, others we selected. Those are the institutions. The School of Medicine had the bulk of the participants at 219, followed by School of Nursing, and then School of Pharmacy 55. In total, we trained 300 participants. Now, the blue bar denotes the pre and the orange is the post-test. So you can see across board, but most of, invariably, all of them had almost about 60% pre-test results. Now, the last one, which is Maseno University, as you can see, it had the most at pre-test 75%, and the post-test was 85%. So I was just alluding to the fact that Jomo Kenyatta University and Maseno University, they had a bit high of pre-test scores due to the early exposure of their students to HIV in the curriculum. But overall, there was improvement showing the learning was effective, and the highest improvement was from Kenyatta University. So in conclusion, the interprofessional training on HIV for pre-service finalist students was effective in enhancing their skills to provide high quality HIV care. Our recommendation is that strengthening of this partnership will be able to sustain efforts so that we can be able to bridge the gaps that had been observed earlier for the pre-service students. Thanks so much. That wraps my conclusion in terms of my presentation. I think I'll have 2 minutes to get questions.
Thanks, Onesmus. That was great. Well, Mike, has he kept the time?
Yes, we have another minute. Yeah, we're all good. Thanks, Dr. Yeah.
Okay, any questions specifically to Onesmus? Can put it in the chat. Okay, here from Flora Katz. How did you measure the interprofessional skills acquisition? Onesmus, did you hear that? How did you measure interprofessional skills acquisition?
Discern or endeavor to differentiate or distinguish between the various cadres. What we did is that for a particular institution, we lumped them together, the pre and the you have the marks before and after, but we did not distinguish them between the various cadres, whether they were from School of Pharmacy or School of Nursing. Ours was a measure of the increment before and after.
Okay, thanks so much. I will go to the next one. Thank you so much from Kenya. We move to Mozambique. So you must stop sharing screen, Onesmus.
Yeah, thank you.
Thank you so much. We have on the chat people say, nice presentation.
Thank you, everybody.
Okay, can you stop share screen? There we go. Okay, Maria, there we go. Okay, Maria, and then full screen, slideshow. You put it on slideshow.
The Mozambican STRIPE HIV team, and we are related to University of Eduardo Mondlane, but we have Professor Emília Nurmomedo is working also for MIER, the Mozambique Institute for Health Education and Research, and also for the University of California, San Francisco in USA. The others are working at UAM. I'm not presenting the STRIPE workshops, but a result of a study which we have done regarding the impact of the STRIPE training on patient care in Mozambique regarding the press service of professionals. I'm presenting a background, the objectives, the methods, the results, conclusion, and I hope to do final considerations. We hope that you know that we are coming from the MAPI to HAPPY, and we are working under the goals and achievements of these programs. With the partnership organized by the UCSF and AFREhealth, and we implemented the STRIPE HIV workshops in 4 MAPI and now HAPPY institutions, which are located in 4 different provinces in Mozambique. These provinces are in different parts of the country, south, center, and in the north. In the center, we include Zambia, which is one province with a lot of neglected areas, with a high level of rural characteristics, and we included this province as a part of our work. We have done this training program, the STRIPE HIV trainings workshop in September in Maputo, October in Nampula and TET, and November in Zambia. When we say Maputo, we are saying that through WAM, we were working also with Central Maputo Hospital and the higher institutions of health education in Maputo, and we have done the same with the State University and the affiliated institutions training health professionals, the same in TET and Zambia. We involved the different kinds of health professionals, like medical doctors, nurses, maternal and childhood nurse, nutritionists, clinical counselors, dentists, doctors, laboratory technicians, and pharmaceuticals also. And we decided to do a research for evaluating the people who were involved, the press service of professionals, evaluating their perception about the impact of the STRIPE HIV training in their daily practice. And we sent to them a questionnaire which was designed for this purpose. It was a self-administered. We started sending by internet, and then we needed to send to them physically because of this pandemic and the difficulty of facilities related to electricity, internet, and other things. But at the end, we could get 40 from 68 participants, and we start showing the attention to some codes. For example, it was really frequent to see this code. Now I am able to assist patients with HIV regarding the disclosure of diagnosis and offer psychological support, meaning that the professionals are taking the patient as a whole, not as a piece like they were done in the past. The other quote is the STRIPE HIV training helped me now how to communicate with the patients and how to work in a care team. As a result, today I am thinking in a different way to treat HIV patients with an approach very different from the one we had during my medical education. And the contents were assessed, evaluated, checked, crossed, and we have found 5 thematic categories based on the contents, and the first one in all of the 40 questionnaires we have this higher confidence and openness to change. And most of the questionnaires were found also awareness of importance of communication with the patients, alertness to value and use of interprofessional communication, motivation to pay close attention to HIV patient needs, and a better understanding of own and others' role in HIV care. Most of these themes we have felt that are the focus of the work during the workshops, and we were happy when we saw this in the questionnaires. We can conclude saying that the STRIPE HIV training initiative was an opportunity to update and discuss health professionals' experience in delivering HIV health care. Although a collaboration and working as a team revealed organizational gaps during the workshops, the participants of the study perceived the positive impact of them on their skills and competencies. The STRIPE HIV training was perceived as a great contributor to subjective improvement in confidence and awareness of the importance of interprofessional collaboration as crucial to deliver of a high quality care to HIV patients. In this regard, I would like to make these final considerations. Improvement in confidence and awareness of interpersonal communication importance may lead to identification of lacking skills and eagerness to acquire them, and to value and respect other existing professional competencies. These situations arising by STRIPE HIV training may call for subsequent organization developments that facilitate breaking barriers, like new local information exchange meetings, leading to new organization norms. In other words, STRIPE HIV may also be seen as a trigger of a sequence of actions worthwhile. I have to say thank you. That's what I would like to share with you.
Thank you, Dr. Rodriguez. Very good English, great presentation, especially that you're presenting research that you did on the impact of the training. Mike, do we have time for a question?
Yes, certainly one question would be great. And I can start, Maria. Just briefly, do you have any sense for how the impact was different between the different professions, doctors versus nurses or others?
We would like to go deeper. We're still working on these questionnaires, and at the same time we are doing a quantitative questionnaire regarding the pre and post test during the workshops. It's only a small piece. This presentation is a small piece of the qualitative study which we are doing. And maybe in the next time we will be able to tell you about that.
Thank you, Dr. Rodriguez. There's another question in the chat box, which we're just going to park for later because our time is up now. Mike, if you're just going to make a note about that. Thank you so much. So then we go to Ghana, and Dr. Dasa will do the presentation for KNUST. So you can share your screen. Maria, you can switch off your video now. There we go. There we go. Okay, so Catherine, you will just need to tell Clara next slide. Okay, so. Okay. You're welcome. You can start.
Okay, thank you. Good afternoon, everyone. On the STRIPE HIV Zambia project, I'm happy and grateful for this opportunity to present our activities. My name is Catherine Ngoma. I'm a senior lecturer and PI for STRIPE Zambia. Next slide. Next slide, please. Okay, so these are the STRIPE project members in Zambia. Next slide. So background information, we have skipped something. Okay, the University of Zambia has 2 campuses, that is the Great East Road campus as well as Ridgeway. So the School of Nursing Sciences is situated at Ridgeway campus, and it's one of the STRIPE awardees. Next one. Next slide, please. Hello. Next slide. Sciences is implementing level 1 STRIPE HIV engagement. This is to adapt STRIPE training curricula and implement 2-day interactive case-based training, targeting the final year students. These are medicine, nursing, and other health-related disciplines, and also the newly qualified health professionals. Next slide. Okay, so far the STRIPE HIV Zambia project has conducted the following trainings. We have conducted 1 facilitator training. This included medical doctors, nurses, midwives, biomedical scientists, a pediatrician, and public health specialists and pharmacists. So a total of 27 facilitators were trained. So other than that, we also conducted two case-based training. This one, two interactive case-based training with pre-service students from different health professional disciplines. Then we also had 1 training using the COVID-19 module, basically to equip students' knowledge on COVID-19 disease. So apart from that, next slide, please. Okay, so the purpose of the project is to integrate innovative approaches to systematically leverage and strengthen HIV training and professional networks, and also target at improving outcomes for people living with HIV. Next slide. Hello, next slide, please. Next one.
Catherine, we are seeing the slides, methods continued, workshop 2 participant students. Is that the slide that you see?
No, the next one.
Okay, Clara, one more. One on methods continue the jigsaw group technique. Is that the right one? Catherine?
The screen is frozen, is it?
So the slide that we see is the jigsaw group technique was applied during the case-based training. Is that the one that you want?
Yes, I wanted the one where we have the case-based training numbers.
There we go, that one.
This one, yes. So as I said earlier, we conducted 2 workshops for a mixed group of students. This is medical students, nursing, pharmacy, biomedical students, environmental health technologists, physiotherapists, and also nursing students. So these students were drawn from University of Zambia and Lusaka Medical Apex. So the first case-based training consisted of 61 participants, as indicated in the breakdown there. The next one, please. Next slide, please. Okay, this was the second workshop where we had 59 participants. It also comprised of medical students, pharmacy students 18, biomedical scientists 15, and nursing students 10, giving us a total of 59. In methods, we use the jigsaw group technique. Okay, so we use the jigsaw group technique during the case-based training. Jigsaw technique involves inputting the parts of the assignment together to form part of the task in a similar way as fitting parts of a jigsaw puzzle. So participants were divided into mixed groups of 5 to 6, and each group had one group leader, the student appointed as a group leader. So within each group, individual students were assigned specific tasks, which they had to master and present to their colleagues in their groups. And within their small groups, students discussed the tasks and reconciled points of view and also synthesized the information. Then each group made presentations to the larger group. So the individual students' participation was measured using a pre and post test. So the aspects that were measured included knowledge, clinical confidence, and interprofessional education. 1 minute left. Oh. Okay, so let's go. Next one. Okay, so these results we are presenting here, they are for the first group of students, that the first workshop which we presented, which we performed. And these are students who are a mixed group of medical students, nursing, biomedical, and also pharmacy students. Okay, so this table shows their pre and post test knowledge scores for the first workshop. So there was an increase in knowledge levels, we would say, from 60.5% to 81.3% in the post test. So we would say that there was an improvement of about 34.4%. Next. So this table is also showing improvement in clinical confidence and interprofessional education. So even here, there was some improvements in these aspects that were measured. So next slide.
Catherine, time is up. Can you wrap up? Give us the...
Hello. Yes, please.
Yes.
Okay, so as we have said, the findings showed an improvement in the students' knowledge levels, and this improvement was also affirmed by the students' post-test comments, such as, "I have learned a lot of new things regarding HIV treatment. The workshop was very informative. The discussions were very rich and enlightening." So it could be concluded that the jigsaw group technique enhances students' group participation, as indicated by the facilitators as well as the students' post-test comments. So interprofessional education appears to enhance learning and other positive attributes among the healthcare professionals. So therefore, having strong HIV management teams is likely to achieve patient engagement within the healthcare system. Thank you. That's the last one.
Thanks so much, Catherine. Very interesting results that you had there, particularly about the technical glitches, but you managed it well. Okay, so we're not, there are one or two questions for you, but we're not, we're going on to South Africa now. Yeah. Thank you, Catherine. You can switch off your video now.
Thank you. The host needs to enable screen sharing, please.
Clara, enable for Ian.
I'm Ian Cooper. I'm from the Uganda Center for Rural Health, and I'm PI of SunStripe. We're not presenting today about SunStripe in general. We are following a similar model to everybody in terms of running SunStripe, but I'm going to talk today about our work, particularly in the Northern Cape province. So the Northern Cape is the biggest province in South Africa geographically, but the smallest population-wise. It's largely rural, there are high levels of unemployment, and there are shortages of health professionals in the province. Uppington is a regional centre in the western half of the province, which is very sparsely populated, and we've been engaged as a university with them since 2018. They're 830 kilometres from where we are based. And in Uppington itself, there's a fairly new regional hospital, which has been a focus of the work that we've been doing there. So we've run the two-day workshop, including 6 modules. So our approach has been not to try and pack too much into the two-day workshops, but 6 modules only over the 2 days. And our focus is on interaction and interprofessional groups. So we've run 4 workshops in the Northern Cape. The first one we ran in October last year. We facilitated it, but we had 12 local facilitators who were identified and 33 participants from a range of professions, as you can see listed there. There was a lot of enthusiasm, and so we followed it up in January this year with another workshop there. We had a training of trainers session first, and that workshop was then co-facilitated with 4 local facilitators, and 2 of those local facilitators took the lead on some of the 6 modules we presented. Again, we had 52 participants this time from a similar range of professions. And these are the kind of feedback we got about the process versus content being important, that people came expecting lectures and were initially disappointed when focus was discussions, but then they actually realized that was better in terms of them learning. They felt it inspired them to make a difference in their learning environment. They liked the multidisciplinary groups, and they felt it was refreshing that we encourage more participation rather than just talking and teaching, which obviously was what they'd been used to. In February, we ran another workshop in Kimberley, 440 kilometers away from Uppington, in collaboration with the Nursing College in Kimberley. Again, we had 7 local facilitators, 60 participants, mainly nursing students this time. But we mention this particularly because the 2 key facilitators from Uppington joined us there, and it became a joint workshop run by 2 of us and 2 of the Uppington facilitators who did brilliantly. And those 2 facilitators then organized a workshop themselves in Uppington. One of us went up to join them, but they basically ran the workshop. And what was particularly significant about this one was that of the 43 participants, most of them were non-clinical. We thought this was quite an amazing idea to try. We had clerks and food service assistants and general assistants and so on. And it actually worked very well. So we really extended the concept of the healthcare team. So some of the feedback, Kimberly, it was great having so many nurses who came from all over the province, many of whom would be going out to practice within 6 months. And we had a fun way of actually setting the ground rules for the 2 days to create an atmosphere which people seemed to enjoy. From that second workshop with the extended team, people enjoyed that it was not just clinically focused, but dealt with HIV more broadly, with community perspectives, looking at things that were seen to be more humane. There was an openness that people enjoyed, a new vision that people had from it, as well as lots of learning that was still happening. We've learned from that sustainability depends on a number of things. It depends on having local trainers, but also local champions, people who champion the cause and people who have a vision to carry it forward locally. And we try to understand why the content that we deliver is actually available online in one form or another. It's not unique in terms of the content, but somehow these workshops really are seen positively. And we think it's because there's an atmosphere of learning as peers. There's a level of engagement with the material. It's not passive listening, it's active learning. There's interprofessionality, which reinforces teams. And we have the involvement of the local facilitators, so there's local ownership. And we think that prioritizing process over content enhances this active learning. And we address team issues specifically. And fascinating for us was the involvement of non-clinical members of the healthcare team. So going forward, there were plans to have regular HIV workshops in Uppington, disrupted by COVID, but the local facilitators remain enthusiastic, and the plan is to deliver these over time and to train more staff. In 2021, that should be, not 2012, sorry, with the possibility of workshops in district hospitals in that part of the province. One of the local facilitators became a COVID-19 facilitator as well, which has been great to have her, and we've ran COVID-19 workshops at a distance with her in Uppington. We're developing guidelines for local facilitators to use. We field test in an online version of the HIV adherence module, which we're testing with the Uppington team on the 14th of October. And we're planning mentoring of local facilitators going forward. If anyone is interested in listening to some of our experiences on running workshops this way, we developed a set of 5 podcasts, which is available on AFREhealth. But that's my story. Thank you.
Thank you very much, Ian. Mike, shall we go on straight to Edward? Let me first hear Edward. If Edward is so,
I think we've lost Edward.
Yeah, sorry, I had to seek refuge in the AFREhealth office, so I think that's. I hope you have my screen now.
Clara.
Yes, so okay. I'm speaking as Clara.
Okay. Okay, your voice is better, but we still need your slide.
Because I'm in mask, so maybe.
Hello? Okay, so don't show your face then. Okay, yeah, it's good. You can see.
Fine
okay, now. It's fine, yes, carry on.
Okay, right. So I'm presenting on optimizing interprofessional education for HIV care in Ghana, our achievements and challenges. I'm doing this on behalf of my co-investigators, Betty Norman and Veronica Zomeku. So that's the outline. And then, well, STRIPE HIV was implemented as optimizing interprofessional education for HIV in Ghana in KNUST in August 2019. Our implementing partners are 2 tertiary institutions and 6 clinical sites. The project sought to train health students and professionals using the STRIPE HIV and COVID-19 models, create additional content, and conduct research. So in terms of our partner institutions, the main one is the Presbyterian University College Agogo. Our clinical sites are 6, made up of Confanoche, Maternal and Child Health, Sontreso, Bekwai Municipal, Obuasi Government, and Presbyterian Hospital. It is noteworthy that 5 of these sites are PEPFAR sites. In terms of the training, we had 2 main sets of training. We had the first one that was in the form of workshops or in-person training. This was from November last year to February this year. And we also had the online or the virtual training. Now, in terms of the workshops, we had 1 trainer of trainers workshop and then 11 trainee workshops. We used 8 of the STRIPE HIV modules, 4 of which were core, that is 1, 3, 4, and 17, and the other 4 were selected. For the online training, we had 2 trainer of trainers workshops. One was specifically for COVID-19, and the other was a combined HIV/COVID-19. We've had 4 online sessions, and we've completed all our trainings. And here we use the STRIPE COVID-19 module and 4 HIV modules. These were modules 8, 10, 11, and 13. Now, the trainings were done as 2-day workshops or online sessions in groups of 50 to 80 participants. These groups are what I refer to as batches in the abstract that was submitted. We also conducted both qualitative and quantitative research. Now, in terms of the outcomes of the training, in terms of the TOTs, we had 2 of them with about 30 participants each. For the HIV workshop, we had 3 levels of the participants, the students, the postgraduate within 1 year, and then the postgraduate after 1 year. For the students, we trained a total of 509, postgraduate within a year, 336, and postgraduate after 1 year, 69, making a total of 914. Now you can see the categories for the various professionals: med lab, nurses, physician assistants, pharmacists, and doctors. Now, in terms of the virtual training sessions, we've conducted 4, and in all we've trained 268. And again, you can see the breakdown in terms of the various professions: med lab, nurses, physician assistants, pharmacists, doctors. In terms of creating additional contents and innovations, we created 5 models of medical legal challenges in HIV care in Ghana. The first one bordered for testing for HIV and maintaining confidentiality, and that was basically for somebody that was mentally handicapped. The second one bordered on partner notification and documentation of HIV results in the records of the clients who did not want a partner or husband to know about it and did not want the husband to be invited for testing as well. The third one also bordered on testing for HIV and maintaining confidentiality in an adolescent patient who comes to the clinic with a mother, and the mother wanting to know what the status of the, what was wrong with the child. The third one is also on confidentiality, care and documentation for a pregnant woman who does not want to disclose her status to the husband, and the sister-in-law works in the same institution, the Ops and Gynae department. The final one is about a deceased patient who, prior to his dying, together with the wife, has told you not to disclose his status to the family. What are you going to record on the death certificate? Bearing in mind that in most of these instances, it's the family members that will come for the death certificate rather than the wife. Then we also we created a website, and where we basically for self-based training, where individuals can use this to train themselves at the comfort of their homes. And then there's also a mobile app also for self-based training. let's look at, this is what the website looks like. And that's the link to the website up there. And in terms of the courses, if you click on courses, you have the HIV. And then for HIV, we have the STRIPE HIV modules there. And we also have our medical legal issues, then COVID-19. In future, if there are any additions, if anything comes up, NCDs or something, we can always add on. So if you click on the HIV modules, this is what module 1 looks like. And then for our medical legal issues, this is what it looks like. Let's look at our mobile app. Now, again, the mobile app is for training individuals self-based, and this is what the home page looks like. And you would see we've called them courses. There are about 3 sets. So the STRIPE HIV modules, 17 modules there. And this is the second bit, which is our medical legal, 5 modules. And then the COVID is 1 module. Now, if you click on the STRIPE HIV modules, this is what it looks like. There's just 3 of them. And if you click on our medical legal issues, this is what they also look like. This is the link to the app down here. In terms of research, we are conducting a number of researches. One is to look at the pre and post test results that are being collected by STRIPE HIV. And so in all, for the workshop training, 833, that's about 91% of the 914 participants did these tests. And I'm happy to announce that we had significant increases in the post-test median scores compared to the pre-test median scores for all participants. Okay, so the average pre-test score was 245 versus 365. And then in terms of the levels of training, pre-service and postgraduate interns within 1 year had significant scores, significant differences. For the postgraduate after 1 year, these did not show any significant difference, mainly because most of these were people working in HIV. All professions, except physician assistantship, also showed significant scores. We are not very sure, but the data suggests that these physician assistants, it was in our partner institution, all their scores were lower, so I think it has to do with maybe the quality of the training. Overall, 94% of the participants expressed satisfaction with our training. We are also looking at readiness of for interprofessional education training among healthcare students. We've also looked, we're also looking at healthcare workers' attitudes towards IPE, and we've looked at perception of health staff about IPE training. And here, this is a qualitative study, and I'm happy to announce that most of them have already expressed satisfaction and think that this is likely to have a positive influence on their practice. What we are seeking to do now with our virtual and then online workshops is to compare, let the participants compare these training sessions. It was the same cohort of participants, a sample of them that were selected for the virtual training, so they'll be able to do this. In terms of challenges, our main challenge has been the reimbursement scheme, which makes it difficult to meet timelines, as our activities are subject to the availability of funds at our college. For the main training, cost of transportation to the workshop sites was an issue for some students who were living off campus. Internet connectivity was an issue, especially in rural areas, both for the workshops and then more importantly for the online sessions. People keep tripping in and off, in and out. And then participants staying till the end of the training was an issue for workshop trainings that were held in the health facility companionship. And the online, it happens most of the time depending on where the person is located. So in conclusion, IP was successfully implemented among health student trainees and professionals. And the results indicate that it improves health students and professionals' knowledge on HIV care. Majority of the participants were satisfied with the training. Key challenges relating to the reimbursement scheme and internet connectivity will need to be addressed. What we need to do now is to assess the clinical impact of the training that we have done. So thank you very much by way of acknowledgement, and we are very grateful. Thank you.
Thank you, Dr. Dassal. That was a very interesting presentation, and I'm glad that the AFREhealth office could help you. Okay, Clara can stop sharing. Okay, so thank you very much to all the presenters. It was really very interesting. Professor Cooper unfortunately have to leave, but one of the other team members are on. If there's maybe one question for Stellenbosch and one to Ghana. Mike, are you seeing any questions?
I have a question for Edward while we wait for others to chat. Can you give us a sense for how well the online training is being received? Obviously, you can't compare, individuals who went through, the online and then the real training, but do you have a sense for whether the experience, that sort of sense for interprofessional collaboration is adopted in the online format, like you are able to see in the real world format?
Okay, yeah, thank you. So yes, it's going on very well, but I think I must say that it's not as, in terms of participation, it's not as active as you have for the physical or the workshops. Because in the course of the training, when we have the breakout rooms, you are mentioning people's names, they are not forthcoming with contributions. But I'm sure if we're the workshop setting, you are looking at the person's face and mentioning, they'll definitely contribute. Occasionally, you may have people having their devices on and probably they are not available. So you are shouting names and they are not forthcoming. I think that's the difference. Otherwise, I think that they have admitted that they enjoy it. And maybe it's also for convenience. People now do not have to travel to one side. You sit at the convenience of your home and do it. And I think they like it.
Mike, there's a question for Edward. They say they like the mobile app for IPE. Is it found in Play Store or wherever? Edward?
Yes, the mobile app, yes, I don't think it's in Play Store yet. We've just finished and we are yet to even deploy it. We've asked some of the trainees to look at it, but we haven't had any feedback. But after this, we'll send it to California. They'll have a look, and then I think that we should be ready to deploy it. But it's working, and those were the screenshots I showed you. And it even appears much easier than using the website, which is internet-based. But we'll send it to California for their comment.
Yeah, that's very innovative. Thanks, Edward. Mike, are you seeing any final questions?
No, I think no more questions in the chat. So maybe I'll just end by thanking Edward, but all of our presenters. I think this is a great session in terms of hearing about the breadth of programs that have been implemented in such a short space of time. That's the other thing, and lovely to see how this is having an impact in terms of the culture of how health professionals education is being done, and HIV specific training is being improved. So I thank you everybody for your participation.
Yeah, thank you, Mike. So as usual, we will put up the presentations on the website. If there's people that particularly want it, please contact Clara and we will send it to you. Dr. Razak also asked for the presentations. Clara, can you send the presentations to Dr. Razak today? So thank you very much to the presenters, to everybody attending, and we hope to see you on the 21st of October with 5 more STRIPE projects. Thank you. Have a lovely day. Bye.
Thank you. Bye.
Bye.
Thank you.